Welcome everyone, and thank you for joining us today for this symposium on directional atherectomy. We're going to speak specifically on utilizing directional atherectomy to treat complex lesions in a case-based and data-driven webcast format. And I think this is particularly relevant today as it comes on the recent release of the reality trial data set presented just 2 months ago. And this was the trial, the first pairing of Medtronic's directional atherectomy device and the impact drug-coated balloon. Joining me today in this symposium are Dr. Krishna Rokasinghe from Prairie Heart Institute in Springfield, Illinois. He was a co-PI of the reality trial. Also joining us, Dr. Ravis Secher, an interventional cardiologist from UNC Rex in North Carolina, and Dr. John Winscott, an interventional cardiologist as well at the University of Mississippi in Jackson, Mississippi. The disclosures as are listed here. I will make note, each of us were participants in the reality trial. This program is provided by North American Center for Continuing Medical Education and HMP Global Company, and is graciously supported by an educational grant from Medtronic. There are 3 key learning objectives, I think, for today's symposium. And these are first to understand recent data and the reality trial as it pertains to directional atherectomy, and how different data sets out there compare in regards to other forms of atherectomy, to be able to apply data to practice and treat long, complex, heavily calcified lesions on a day-to-day basis, and finally, to identify those cases when directional atherectomy can be followed by drug-coated balloon to optimize patient outcomes. So with that introduction, I'd like to turn the microphone and the camera over to Dr. Rokasinghe, who will take us into the reality data set. Thank you, Dr. Rokasinghe.
Dr. Scott, thank you very much for that exceptional introduction. On behalf of Viva Physicians and the reality investigators, it's my pleasure to review with you the primary endpoint assessments of the directional atherectomy plus drug-coated balloon in the treatment of long calcified femoral popliteal lesions, the reality trial. So the reality trial was designed to evaluate some very essential hypotheses as it relates to the treatment of very complex calcified lesions. We understand that from adjudicated registries, specifically the imaging cohort from Impact SFA, that long calcified lesions, and we'll discuss a little bit about what calcification means, is associated with high rates of provisional stenting. We know from the definitive LE trial, a large randomized adjudicated registry, that directional atherectomy is also associated with reduction in plaque volume, reduction in vessel recoil, can reduce high-grade dissections, and potentially reduce the rate of provisional stenting. Importantly, there's been preclinical data that suggests that the intimal disruption by atherectomy devices may promote the uptake of the lipophilic drug paclitaxel and actually allow its uptake into the vessel wall media and potentially attach to the putative smooth muscle cell and potentially reduce intimal hyperplasia. As such, the Viva Reality trial set therefore to look and to evaluate the safety and effectiveness of the treatment strategy involving directional atherectomy in these long calcified femoral popliteal lesions prior to the application of the paclitaxel drug. The use of the word complex, the word severe, the word heavy, as it pertains to calcification was an immediate challenge in the designing of this trial. We wanted to look at clearly long lesions, and we enrolled lesion lengths from 8 to 36 centimeters. We also wanted to look at the association of these long lesions with CTOs, and indeed we looked at a high incidence of long lesions and total occlusions. And we sought to define in a more realistic manner the definition of severe calcification. And we looked at bilateral wall calcification as a requirement for the enrollment of these patients in reality. Importantly, reality looked at a pre-specified novel calcium grading scale, the peripheral artery calcification scoring system, the PACS system. And this has grades 1 through 4. We included only PACS grades 3 and 4, which looked at contiguous bilateral calcification as defined under fluoroscopy. But more important than looking at bilateral calcification, which has been hypothesized by Finelli et al. As being potentially a impediment to the uptake of paclitaxel, we actually looked at an additional metric, and that was the PACS index. Core lab adjudication of this PACS index looked at the summation of bilateral calcification and divided it by the lesion length and multiplied it by 100. And so we were able to, at any length of lesion, actually determine the percentage of that lesion length that had bilateral calcification. We also assessed the location of the calcium, whether it was intimal or whether it was medial or adventitial. So we prospectively defined, in reality, what we felt to be one of the major drivers of potential loss of clinically driven TLR and or procedural complications, and that is calcification. I'd like to call out my colleagues, Dr. Shakar and Dr. Scott and Dr. Winscott, for their contributions to this multi-center international trial. I think it was important to include our colleagues in Germany to really interject a diversity of approaches to these complex lesions. I'd like to go over the reality patient flow because I do think it really reflects exactly the challenges that we met during reality. We screened 400 patients, and to your right, we see that almost 300 of them did not meet the entry criteria. And I can tell you that the vast majority of them did not meet that criteria because they did not have sufficient either length or calcification. We enrolled 102 patients, and there to your right, you see the patients that during follow-up either expired, withdrew, or were lost to follow-up. The bottom, you can see that we had 100 patients reaching 30-day follow-up, 6-month follow-up, and 92 patients in this very difficult to enroll cohort reached 12-month adjudication. This demographic shown on this slide, I think, reflects the typical demographic of a claudicant population. You see the prevalence of hypertension, dyslipidemia, diabetes, and smoking. And this is obviously not to be, this is not unexpected. I'd like to spend a little bit of time on the lesion and procedural metrics that I really think reflect and define the complexity of this cohort. You see here a mean lesion length of 18 centimeters, but importantly, you see also a chronic total occlusion length of 22 centimeters, of which 40% of the patients had CTOs. So you can see right away the complexity of these patients as it relates to the criteria. I want to reflect a little bit upon the procedural metrics here. Baseline percent diameter stenosis is noted at 88%. And we looked at what the interval atherectomy reduction in percent diameter stenosis that you see went from approximately 90% to 40%. And then what the final percent diameter stenosis was after the application of DCB, and you see that at 28%. Now at the bottom there, you see that we pre-specified procedural success, and that procedural success was defined as less than 30% residual stenosis after both atherectomy and DCB. And that was basically a signal that was derived from the definitive AR trial, which we will discuss a little bit later. So importantly, you can see that we at every stage looked very closely at the procedural metrics as a resultant of both atherectomy and the DCB. As it relates to calcification, I think you'll see here that grade 4 was present in almost 70% of these patients, again reflecting the complexity of the cohort. And importantly, we look at the PACS index, which was 55%. So what does that translate to? That suggests that in a mean lesion length of 18 centimeters, that almost 56% of that lesion length had bilateral calcification, which again, I think reflects the severity of these patients that were enrolled in reality. Importantly, when we look at procedural complications, this was an adjudicated trial, a prospective trial that had 3 core labs. And we were able to, at each point, look at the procedure-related complications. Importantly, I want to suggest to you that in this very difficult cohort, only approximately 9% of patients required provisional stenting. You see here the rates of perforation, Class C dissections, and embolizations. Let's talk about embolizations for a while, because this device in the treatment of bilateral calcification, this metric I think is very important. Embolizations you see occurred at the noted rate, but importantly, you see the embolizations that were subclinical, and the investigator felt that they did not need to pursue any adjunct therapies. The vast majority of the embolizations that you see required simply aspiration only, and one required stenting basically to remove the atheroma from the luminal surface, the luminal from the vessel lumen. So I think this is very important, and it calls out the importance of the use of distal protection devices. I can suggest to you that in no case was the distal protection device removed during the procedure and a second distal protection device used. And in only one case was a distal protection device not used. So here you see the safety outcomes as it relates to 30 days, 6 months, and 12 months as it relates to major adverse events, all-cause death, and amputations. Duplex Doppler defined patency, again, that you see at 30 days. I think these are fairly well-established definitions. Importantly, the primary effective endpoint that we pre-specified, a 12-month primary patency, was noted at 76.7%. And if you look at this Kaplan-Meier, you see that we extended the adjudication of patients beyond the typical window of 365 days plus or minus 30 days. And I think that was important because we had this patient that actually came in late, but was available to us, and we included this patient in our primary effectiveness endpoint assessment. When we look at a clinically driven TLR through 12 months, we note a CD-TLR freedom from clinically driven TLR of 92.6%. Again, suggesting actually at 12 months a very good clinical response to this therapy. When we look at both Rutherford classifications and ABIs through 12 months, you see on the left panel the improvement at 6 and 12 months as relates to the Rutherford class. You can see here at baseline, basically absence of 0 and 1 Rutherford classifications, and as it progresses through both 6 and 12 months, the marked improvement, statistically significantly and clinically relevant improvement in Rutherford class. And on the right side, the improvement at 30 days and 12 months of ankle brachial indices, likewise conveying a significant clinical improvement as relates to this metric. Now it has to be discussed the generalizability of the results of reality that look specifically at directional atherectomy and a specific DCB platform to other modalities, whether it be other atherectomy devices or potentially fragmentation balloons and other DCB platforms. I think it should be noted that the HAWK1 atherectomy, directional atherectomy system is unique in its methodology, its actual cutter. And importantly, and I didn't go into it too deeply here, but it's well defined in our manuscript that we actually had a histology core lab. And in this cohort of 46 patients, US patients, we actually sent all atheroma that was removed and had a core lab actually do histology. And we noted that close to 90% of all atheroma revealed calcified tissue, which I think reflects, again, to the efficiency of the device in removing what we believe to be an important barrier to paclitaxel. Notably, likewise, almost 40% of the tissue analyzed by our histology core lab contained adventitia. And there was obviously a concern that this deep tissue that was removed, and then the application of an antimitotic may actually promote major adverse clinical events. However, when we looked at the data, there was no association in those patients that had deep tissue adventitia removed or external elastic lamina removed and subsequent clinical events. So in conclusion, I think reality demonstrates that a vessel preparation strategy that uses directional atherectomy prior to the application of DCB angioplasty and long calcified lesions is both safe and effective through 12-month follow-up. Importantly, again, this shows that this application of this strategy resulted in a low provisional stent rate of less than 10%, which is a significant departure from other DCB trials as a standalone therapy in this complex population. And finally, the reality trial established the PAX index as a novel assessment of the degree of calcification that needs further study and validation. Thank you very much. Now I'd like to turn it over to Dr. Eric Scott for a discussion. Dr. Scott.
Thank you, Dr. Rocha Singh, for so nicely presenting that reality data to us. A lot of detail there. I think when we as investigators set off on this trial, we knew we were looking at the most complex of femoral popliteal lesions. And you brought forth numerous data points that I think are notable. A freedom from TLR rate of almost 93%, primary patency of about 77%, and a provisional stent rate of less than 9%. Of some of those key endpoints, are any one of these most compelling to you?
Well, I think all of them are. I think if you look at the available data, particularly the adjudicated registries and long lesions that came out of the IMPACT imaging cohort, where as you increase just the lesion length, the provisional stent rate increases incrementally. And while we've always purported leave nothing behind, that actually came out of the initial atherectomy nomenclature. So I think this actually reflects really on the importance of, if you believe that using a lot of metal is something that should be avoided, this gives you the opportunity and using this strategy to promote that. I think primary patency out to 12 months, it would have been obviously very interesting to see what this looked like in 2 years. But I do think always CD-TLR rates are always look better than primary patency rates. And I think that dichotomy as it relates to clinically driven TLR is likewise important. So, when you look at this data set, again, adjudicated with an angiographic core lab, a duplex Doppler core lab, CDC adjudicated with a histology core lab, this type of data, I think in our clinical acumen is rarely available to us.
I think for all of the challenges that these patients brought to me, I know in the trial, I was impressed that the provisional stent rate was less than 10%, to be honest with you. Dr. Winscott, what was your take on the low stent rate in this trial? And as a frequent femoral popliteal operator, what does that low stent rate mean to you, your practice?
I think when you look at this complex lesion set, I think Christian did a great job of showing you the PAX index and the fact that we've really never had a trial that looked at lesions this long that were greater than 50% calcified throughout their lengths. So to be able to do that without stenting, I think, like you said, is quite remarkable. In my personal practice, I avoid stenting below the inguinal ligament at all costs. And the way I've been able to do that in my practice with very long calcified lesions is with directional atherectomy. And you see in the data that just after directional atherectomy, you're able to achieve a less than 40% residual stenosis. And I think what leads to dissection, which subsequently will lead to stent implantation, typically is either dissection or lack of lumen gain. And the Hawk is able to overcome those obstacles very well in calcified lesions by effectively debulking. And so I think the specific qualities of the Hawk 1 device, especially with the more powerful motor over the first 2 generation devices, allow us to debulk that calcium to a point where we can apply an an appropriately sized DCB to obtain the lumen that we want without any flow limiting dissections. And that's what I've seen in my practice over the past 5 years. And honestly, what I saw in the trial was very reflective of what I've seen in my practice.
So in your practice then, John, if somebody can provide you a therapy that is equal in patency, freedom from TLR, but you can do so without a stent implantation, that'd be your preference?
Absolutely. And that's been my practice for about 10 years, really, since the TurboHawk device launched and we were able to debulk lesions like this without and be able to generate lumens without stenting. That has been my standard practice, and I think is very preferable over a scaffolding strategy in these patients.
Certainly. Dr. Setcher, I think it's an ongoing debate as to how you optimally treat difficult lesions in the femoral popliteal segment. What is your preference? Scaffolds with patency data, or do you feel like there's tangible benefit to trying to stay stent free in this zone?
Yeah, that's a great question, Eric. And you know, for those of us who have believed in a leave nothing behind strategy for many years, this data set here really validates that strategy, and that we can achieve good outcomes in these complex patients with a strategy that does not routinely include a scaffold. So just like you heard right now from Dr. Winscott, my strategy is the same. Where I can, I try to avoid using a scaffold, because once you put a scaffold in, then you now have a permanent change in the vessel architecture that cannot be changed. Now, if that stent closes down, you can go through that stent sometimes, revascularize, but sometimes you can't, and your options then become limited. So if you can treat these patients in a way that you maintain future treatment options for the patients as long as possible, well, that is preferable. And as technology is involved and atherectomy devices have improved, as we've gone from TurboHawk to Hawk 1, and now with the advent of drug-coated balloon technology in conjunction with that, we now have data that in many cases equals or sometimes surpasses the data from scaffold technology. So now that we have these data available, I think it validates some of the efforts that many of us have made over the years to approach the femoral popliteal segment in a scaffold-free way.
So on that topic of comparability, Dr. Roka Singh, I want to go back to you for one last question before we move on, and that is, in today's era, there are more atherectomy devices on the market than I can fit on one hand. There are now 4 commercially available drug-coated angioplasty balloons. How fair is it? How realistic is it to take the efforts of your trial here and you think cross-apply it to other devices, other drug-coated balloons, other combinations of these therapies? Is that valid?
Well, excellent question that begs the answer I'm going to give you. There is actually no generalizability to this technology, specifically directional atherectomy, excisional atherectomy, however you want to call it, and other modalities that are under the general rubric of atherectomy. Likewise, the DCB, we can debate till the cows come home whether there's a class effect across all DCBs as it relates to impact versus Lutonix versus Stellarex and so forth. I invite my colleagues and the other strategics actually to invest in the clinical space to the extent that Medtronic did in providing this grant to Viva physicians to do this. The short answer is no, it cannot be generalized, but that doesn't mean it won't be, and I suspect it will be. And one last point, if I can, Eric. I think the depth and breadth of this adjudicated data shows the challenges in taking care of these type of patients as it relates to distal embolizations and some of the procedure-related other issues. And I really do think it's important that other strategics actually really join all of us in purporting and advocating for this type of data to help us make these type of decisions for our patients.
No, this was an incredibly challenging cohort of patients, as you point out, and we thank you for all of all of the efforts you and the other trial organizers have put into this challenging set of patients. So congratulations to all of you. To follow on the heels of that discussion, I now want to turn the microphone over to Dr. Ravish Secher, who's going to put into context the reality trial data just discussed and presented into the setting of other atherectomy data that's available to us. Dr. Secher.
All right. Hello, everyone. I'm Ravish Secher from Raleigh, North Carolina, UNC Rex Healthcare, and it's a pleasure and honor for me to be here today. Excellent presentation about the reality data by Dr. Krishna Roka Singh, the co-PI of the study, really adding a lot of data for complex patients. I'm going to be talking a little bit about putting the reality data into context. Let's start off by looking at atherectomy in general, not just directional atherectomy, but atherectomy in general. The purpose of atherectomy, of course, is to remove plaque from the vessel and to debulk the vessel in the hopes of improving vessel compliance and improving the lumen size and hopefully improving long-term patency as well. Several types of atherectomy are now available to us, and several trials have been done for atherectomy in the femoral popliteal segment. There's orbital atherectomy, there's laser atherectomy, rotational atherectomy, directional atherectomy, and OCT atherectomy, which is really directional atherectomy, but using OCT as a way to guide therapy. Atherectomy is widely used, but the amount of data that's available for atherectomy in the femoral popliteal segment is not as much as you would expect. This slide over here looks at the various trials that have been done for atherectomy in the femoral popliteal segment by the type of atherectomy device that was used. As you can see, the majority of the trials that have been done have sample sizes of less than 200, not very large. The largest trial that was done is a definitive LE study, which is now several years old. And this was a trial of directional atherectomy, which was used to treat patients with claudication as well as in patients with critical limb ischemia. And what this study found was that at 12 months, among patients with claudication at baseline, the patency was 78% for a mean lesion length of 7.6 centimeters. And among patients with critical limb ischemia at baseline, the mean lesion length of a little less than that, approximately 6 centimeters, the patency at 1 year was about 71%. So these were results with directional atherectomy. Now, when you start looking at other trials, it's important to understand that these are not apples to apples comparisons. These other trials had different inclusion criteria, different exclusion criteria. The lesion lengths were different, and so on and so forth. And so it's really not an apples to apples comparison. But with that in mind, we can look at some of these other trials. Pathway PVD, for example, was a study of rotational atherectomy. And in this particular study, the 12-month primary patency was 61.8% as adjudicated by duplex ultrasound. The Excite ISR study looked at laser atherectomy in patients in the femoral popliteal segment who had in-stent restenosis. The patency data are available only at 6 months, and that was 71.1%. And laser atherectomy was also looked at in the femoral popliteal segment in a randomized manner, but in a small study. And in this study, the patency in non-stented segments of the femoral popliteal artery was 54.3% at 1 year. All the other trials that have been done looked at freedom from clinically driven TLR or acute results, but did not report patency data. So looking at these same data in a slightly different format, in a table format, you can see over here, if you look at the right side, these are, again, all the studies that have been done looking at various atherectomy devices in the femoral popliteal segment. You find that only 4 reported patency data at all, 3 of them at 1 year, and 1 of them at 6 months, which was the Excite ISR. But none of them looked at patency data beyond 1 year. So for a therapy that is used as much as it is, there really is a paucity of data to guide our therapy and what kind of outcomes we can expect in these patients over the long term. The data are quite heterogeneous. The trial designs are heterogeneous. The sample sizes are heterogeneous. And so it leaves us somewhat unclear in terms of what we should do in a lot of our patients when they present with disease in the femoral popliteal segment and how atherectomy will perform. In one area, though, where there does seem to be uniformity is that atherectomy uniformly seems to reduce the risk of dissection when it's followed by balloon angioplasty. As you can see over here, when atherectomy is performed first, regardless of the type of atherectomy, the risk of dissection, grade D or higher, becomes quite low. in most cases less than 5%, in almost all cases less than 10%. And as a corollary to that, the risk of bailout stenting or provisional stenting also becomes quite low, because if there's no dissection, the risk of stenting is lower. And the risk of bailout stenting, regardless of the type of atherectomy used, is also similarly low, in most cases less than 10%. And so while the trials are quite diverse and heterogeneous with different sample sizes and inclusion-exclusion criteria, and the patency data are few, and those that are available are quite all over the map, we do find some uniformity in terms of the benefit of atherectomy acutely at the time of treating the lesion, in terms of the risk of dissection, grade D or higher, and the risk of bailout stenting. And so this led to the question that if atherectomy can reduce the risk of dissection and bailout stenting by removing plaque, if that is followed by drug-coated balloon angioplasty, will there be a benefit not just in the short term in terms of acute outcomes, but also in the long term by using a DCB and hopefully improving vessel patency, not just by the delivery of drug, but furthermore by the improved delivery of drug by debulking the lesion and allowing more drug to get into the media and the adventitia. And the reality study, as you just heard the outcomes for, examined exactly this hypothesis. This hypothesis was first looked at in a pilot study called the Definitive AR study. This study the PI was Professor Zeller, and this study was published in 2017. As I mentioned, this was a pilot study, 120 patients. Of these 120 patients, 20 were in a registry in which patients had severe calcification in the femoropopliteal segment. The remaining 100 patients were enrolled in the randomized portion of the study. About half the patients had a strategy of directional atherectomy followed by DCB, and the other half had DCB alone. These patients were all followed out to 1 year and all underwent angiographic follow-up at 1 year. And what the angiographic follow-up at 1 year showed us was that the overall cohort did not show a difference, a significant difference in terms of patency at 1 year between the two strategies. But it did show that there were two subsets, those patients with lesions more than 10 centimeters long and those patients with severe calcification, that these two subsets seem to have a benefit of a strategy of atherectomy first, followed by DCB, as compared to DCB alone, when looked at in terms of angiographic outcomes at 1 year. But the sample sizes in these subsets was quite low, as you can see, somewhere in the 7 to 22 range. So while this was a pilot study and hypothesis generating, it did not answer definitively whether this was the right strategy for our patients or not. And so this is what led to the reality study, as you already heard, the data for. What reality did was not just enroll patients with long lesions, not just enroll patients with severe calcification, but patients had to have both to be enrolled. And as you heard, approximately 300 patients were screen fail, and majority of those screen failures because they did not have the length of lesion required to be in the study or the severe calcification or both in order to be in the study. And so in order to be in reality, which enrolled the most complex of patients, those patients in whom we weren't even sure if endovascular first was the right strategy, this patient cohort was found at the end to have bilateral calcium in 86.2% of patients, intimal or medial calcification in 86.3% of patients, a mean baseline diameter stenosis of 88.8%, 39% of patients had chronic total occlusions, and the mean length among those patients with CTOs was approximately 23 centimeters. And the mean overall length in the study was 17.9 centimeters. So a very complex group of patients. And if you look at how this compares to other studies that have been done in the femoropopliteal segment, you find a number of studies enrolled patients with long lesions, a number of studies enrolled patients with complex lesions and calcific lesions. But reality really stands by itself in terms of the combination of both length as well as calcification, and therefore the most complexity as compared to other trials that have enrolled patients with disease in the femoropopliteal segment. So the outcomes that you heard, the 77% patency in the reality study and the 93% or so freedom from clinical TLR, excellent outcomes, was achieved with a very low bailout stenting rate of 8.8%. So this slide, it's a busy slide, but looks at the various studies that have been done in the femoropopliteal segment and compares them in terms of lesion length and the risk of bailout stenting. So on the left side, you have studies which had the shortest lesions, and that's shown in the red bar, and the corresponding risk of bailout stenting shown in the gray bar. So on the left side, you see short lesions, 6.3 centimeters with a bailout stenting rate of 2.5%. Now, as you go to the right, you find increasing lesion lengths, and as the lesion lengths are increasing, the risk of provisional stenting or bailout stenting also correspondingly increases to where you get to lesion lengths in the 20 to 25 to 28 centimeters with bailout stenting rates approaching 40 to 42%. But then you have the reality study with perhaps the most complex of lesions, with long lesions, 17.9 centimeters, chronic total occlusion length mean of 23 centimeters, excellent outcomes with clinically driven TLR of 93%, patency at 77%, but with a bailout stenting rate of 8.8%, much lower than what you would expect in similar studies with long lesions. So you can achieve these outcomes in complex patients, but with a lower risk of bailout stenting. So in summary, there are several types of atherectomy that are available to us. It's hard to compare outcomes of these atherectomy devices when used in the femoral popliteal segment because the trials have had heterogeneous designs and the inclusion and exclusion criteria have been different. However, atherectomy uniformly appears to result in a reduction in the risk of dissection if angioplasty follows atherectomy and the risk of bailout stenting if angioplasty follows atherectomy. The reality study, which included very challenging patients, showed excellent outcomes in this challenging group of patients, and these outcomes were achieved with a low 8.8% risk of bailout stenting. So thank you for your time, and Eric, I'll turn it over to you.
Thank you, Ravish. That was very nicely presented and an excellent comparison, I think, of reality data just gleaned to the myriad of drug-coated and drug-eluting device data that we've compiled over the last 5 years. So that some of the slides that you showed were the latest, the most up-to-date slides. So I thank you for that comparison. I think one of the points you made particularly well is that patients in reality, in a sense, they had the most complex lesions of any study that's been done in the last several years in terms of length paired with calcification. These patients were in a class of themselves. And I think if you go back to some of the data Dr. Roka Singh presented tonight, I think more than 70% of these patients were smoker, over 80% of them were diabetics, if I'm not mistaken. So the patients, the lesions were most challenging. When you study a subset of patients like this, however, that's narrow, you then I think we all want to know, what do you do with this data, knowing that the patient I treat tomorrow may just have a simpler lesion. They may not be a reality patient. So I'm curious, this is our first look at directional atherectomy and impact drug-coated balloon, but it's to a specific small subset of patients. How do you apply this? Can you apply this to the everyday?
That's a great question, Eric. That question is normally posed in the other way, in that you have studies which look at patients with less complex patients. And then the question is, well, what do you do when you have more complex patients? Because that tends to be what you see on a daily basis. Your question is a little bit different. We now know what works in very complex patients, but it requires some work, it requires atherectomy. That atherectomy takes some time, it requires embolic protection, it requires drug-coated balloon angioplasty, it requires some persistence to get this done. We know the results are good. One would expect that if the same strategy is followed for less complex patients, the result could only be better. But I think the question you're posing is the effort and the time and the cost you spend on this worth it if you have less complex patients? And I don't know the answer to that. I would say that if you look at angioplasty alone with drug-coated balloons in long lesions, the results are actually quite good, in the high 80s in terms of patency at 1 year. And now we have good data in terms of patency after 3 years and freedom from clinically driven TLR up to 5 years. So it's hard to argue against those data when you have simple lesions and using just drug-coated balloons alone. And so should you, in those patients where you have simple lesions, a 4-centimeter lesion, eccentric, non-calcified, should atherectomy be used first over there, followed by drug-coated balloon? Is it fair to say that if the outcomes with a drug-coated balloon are close to 90% alone, that if you use atherectomy plus drug-coated balloon, it'll be more than 90% because I'm now removing some plaque, I have better delivery of drug? Or is it that I'm just being too aggressive, potentially creating more risk for the patient, more cost for the patient, and I'm better off just with angioplasty alone? So I don't know the answer to that. I think that needs to be looked at. I'll tell you, my approach is that I want each patient to have the best possibility for long-term outcomes, especially for claudicants. These are usually patients who are going to be coming back for recurrent procedures over and over. So the longer I can wait or create the length of time between procedures, the better off they're going to be. So I tend to treat most patients in this manner, even if they're not complex, because my hope is that I'm going to create a better long-term outcome for them and a longer time before they have to come back for a repeat procedure.
I think that's a nice way to put it, Ravish. It's a difficult problem. I think clearly there's evidence that to your point, that drug-coated balloon angioplasty can suffice for shorter lesions, less complex lesions. And I guess in my practice, the limitation I think that mindset brings us to is the unpredictability of dissection with balloon angioplasty. And to your point, there are patients who may have the shortest, simplest lesions, but it's either in a younger patient with small arteries, or it's near a bifurcation where you simply, as the operator, don't want to take the chance on a dissection. You don't expect it. You don't think you'll get it, but you'll hate yourself as the operator if it pans out that way and you have to put a stent in some of those circumstances.
And that's especially true in the so-called no stent zones, a common femoral artery, the popliteal artery, where you're kicking yourself if you do angioplasty and then you have to put a stent in because of a dissection. So I completely agree with that.
Dr. Winscott, your thoughts?
Yeah, I was going to reflect exactly what you just said. I think it's the inherent unpredictability of balloon angioplasty, and to bring up the point that you're dealing with an individual patient on your table, not 92 out of 100 or 920 out of 1,000. And so if you have a patient on the table and you choose to treat them with what I would consider an inferior treatment algorithm, and you end up with an implant, then that patient becomes a problematic patient that has recurrent restenosis and ultimately may require a surgical bypass. When if you had taken 5 extra minutes to do good atherectomy, followed by the DCB, and given them the best possible outcome, you could have avoided that entire situation. So in my personal opinion, having been doing this for over 5 years, I think that cost benefit ratio, if we looked at it, I think it would be favorable just because of the decrease in redo patients that I've seen in my practice. And then not creating those patients that are very problematic and short-term recurrent procedures. I think it's worth it without doing a randomized trial to prove it. In my experience of almost 3,000 directional atherectomy plus DCB patients in my practice here in Mississippi, I think it is very beneficial for combination therapy to avoid permanent implants, to avoid recurrent procedures over a long period of time, especially in a claudicant population. But honestly, in my patient population also applies to a CLI group as well. But here we're talking about claudicants, and claudicants are the long-term freedom from TLR. I think DART is by far the best way to treat those patients.
Dr. Roka Singh, back to you. You have been integrally involved in numerous of these femoral popliteal trials over the years. You treat patients every day. Have you personally evolved to some sort of femoral popliteal algorithm based on different data sets, different trials, different patient subsets? Is there clarity in your world now?
I wouldn't use the word clarity. I do think I'm coming, the fog is sort of lifting from my cortex year after year. I think in reflecting on what Rajesh suggested, not all lesions require atherectomy. I do think that's true. I think the randomized controlled trials that looked at a very low bailout stent rate, you can see that, you can see those results. I think as we progress and treat these patients that are not part of clinical trials, I think the primary drivers for me are what we addressed in reality. And I think these are the calcification and CTOs. And CTOs, I think, at any length become problematic because it's the company it keeps, and the company as CTO keeps is calcification. And I reflect on how we've emerged from the insights provided by Dr. Fornelli looking at CTA and circumferential calcification. I wouldn't advocate that atherectomy is necessary in all lesions. I think we can only look at the DCB cohorts for that. But I do think I am emerging to a treatment strategy that suggests vessel preparation that actually modifies plaque, needs further evaluation. And as you suggested, we can do all the potential iterations of fragmentation balloons and various atherectomy devices, plus or minus these various DCBs. I think some clarity is coming to us. And just as it's coming to us, we're going to be moving into bioresorbable scaffolds and so forth. So I think this clinical subset's always going to be interesting and very exciting. That's what makes the practice of medicine so engaging.
So true. Thank you all for all of your insights. At this time, I want to turn the microphone over to Dr. John Winscott, who will take us through some of his specific patients entered in the reality trial. Take it away, John.
Thank you, Eric, for that introduction. What I'd like to do over the next few minutes is just demonstrate for you several examples of patients who were involved in the reality trial and what their outcomes were and the types of lesions and complex lesions that were involved in this trial from my own practice. So our first patient is an African-American man in his late 50s with multiple risk factors. He came to me with lifestyle limiting claudication, Rutherford 3, with abnormal ABIs. His lesion length is 30 centimeters. The occlusion length is 10 centimeters, and we categorize his calcium as moderate to severe. You can see here on the angiography, it's a left lower extremity. The common femoral is patent. The profunda is fairly free of any significant disease and provides important collaterals to the popliteal. He has diffuse disease of the mid SFA and then complete occlusion of the distal SFA with reconstitution in the proximal popliteal. So we were able to cross that lesion with just standard wire and catheter techniques. We performed directional atherectomy with the Hawk 1LX device, as you see here, and followed that up with drug-coated balloon angioplasty with 2 6-millimeter diameter impact abdominal paclitaxel coated balloons. The angiographic result at the conclusion of the procedure, you can see, I think anyone would argue that this is a less than 30% residual stenosis throughout the length of the CTO and the entire lesion length that was treated with brisk flow in the entire FemPop segment. As per the protocol of the trial, at 1 year, his ABIs are recorded here. He has multiphasic waveforms at 0.9, again, significantly improved from previous. He has a 1-year duplex, which shows multiphasic waveforms within the treatment lesion. Here you can see this measure was made 10 centimeters within the treatment lesion itself. And he remained Rutherford category 0 for the entire year of follow-up. What's really interesting about this particular patient is he came back in at a later time, not as part of the trial, to have his other leg evaluated, and that was done at 30 months. And so this is 30 months following the treatment that was included in the reality trial, and you can see his FemPop segment, you would argue, looks almost identical to what it looked like at the conclusion of the treatment almost 3 years previous. So I think this is a great example of not just the 1 year, but almost 3-year patency that we see when using directional atherectomy performed to a residual stenosis less than 30% and following that up with the impact admiral balloon. This is the type of the results that I've seen in my practice. In a second patient I'm going to demonstrate for you, this is an older patient, multiple risk factors again, Rutherford 3 symptoms, a longer lesion, 36 centimeters, which is the upper length that we were able to include in this trial with an occlusion length of only 9 centimeters. But in this particular situation, the calcium was considered severe. And you can see again a left lower extremity, a patent proximal SFA, and a small profunda, but fairly free of disease. The common femoral has mild disease. some moderate disease of the mid SFA, severe disease in the distal SFA, complete occlusion of the distal SFA, and proximal popliteal, the reconstitution of the P2 segment of the popliteal. You can see on just single frame fluoroscopy how severe the calcium is. And so we looked at the PAX index, which is basically a measurement of what percentage of the length of this treatment lesion had bilateral calcification. You can see it has bilateral calcification almost throughout its length. And in the distal portion, this is the proximal popliteal that was completely occluded. You can see how severely calcified this vessel is at both the adventitial, medial, and intimal levels. And so I would argue that this patient has a PAX index of actually greater than 80%. So we were able to cross through that occlusion, integrate, and just standard wire and catheter techniques, apply the Hawk 1 LX device to that lesion, and follow that up with 3 impact SFAs. Of course, nowadays we'd use the longer balloons. They weren't available to us at this time. But 3 6-millimeter impact balloons, and you can see they're well expanded following good directional atherectomy. And you can see again we have excellent lumen gain of this occluded segment of the FemPop segment, especially the occluded proximal popliteal. And at 1 year follow-up, he has normal ABIs at 1.1 with multiphasic waveform in the posterior tibial artery, which was his single vessel runoff to the foot. The anterior tibial artery was diseased at the time of treatment and was not treated in this claudicant. And at 1 year, his duplex was completely normal. You can see a biphasic waveform, which was measured 34 centimeters into the treatment lesion, which obviously was within that occluded segment of the popliteal artery. And I have a still frame image here on the right, just demonstrating you just how severely calcified the wall of this vessel is. And yet at 1 year, we have a widely patent vessel and a Rutherford category 0 patient who was previously very limited by his claudication. So with that, I'm going to turn it back over to Eric for some more discussion.
Thank you, Dr. Winscott, for presenting some truly amazing cases from the reality trial. I want to ask each of the panelists that are with me today about some of the things that you personally learned from participating in this trial when the trial asked you to combat some of the most severe lesions with directional atherectomy. John, I want to start with you first. Are any of these cases that you would tackle with a 6 French Hawk, or all of these 7 French Hawk? And then the second part of the question to you is, how often are you using IVUS to pick the right angioplasty balloon for the femoral popliteal segment?
That's a great question. So I'll tackle the first question first about which devices that I typically use. And so I'm a very big fan of the 7 French devices, the LX and the LS and the Hawk 1. All of my reality cases were done with the 7 French devices. I don't use the 6 French devices very often, really only when I feel like I'm restricted to a 6 French device because of a problem with access. So a difficult crossover because of previous iliac stents, a previous EVAR, a previous aorta bifim, some reason I'm having trouble getting in a 7 French sheath, or that I feel like a 7 French sheath is going to be occlusive in a patient who has severe common femoral disease. In the vast majority of my patients, greater than 95%, when I'm treating the FemPop segment, especially in complex lesions like you see represented in this trial, I'm going to use the 7 French device. And that's from a cardiologist who grew up doing all my PCIs 6 French. I quickly adopted to the 7 French sheath and use that routinely. We use micropuncture for our access with very meticulous choice of where we puncture the vessel. And we follow that up with a closure device that leaves nothing behind inside the vessel. And that's been my strategy. And we get that away with that with very low access complication rate. So I have no reservation whatsoever using 7 French in the average patient, even in calcified common femoral dialysis patients that we typically encounter. The second part of your question for IVUS. So, in the reality trial, we didn't really talk about the IVUS much, but we were blinded to the IVUS. So we really couldn't use that IVUS data to help guide our therapy. I grew up as a cardiologist sizing vessels and I feel very comfortable sizing vessels off angiography, especially on certain magnifications. If there's any question about sizing a vessel, especially below the knee, which I find in training, I actually, in my practice, run our interventional cardiology and vascular surgery training programs. And so I train a variety of different fellows. And I have fellows that struggle in sizing vessels, especially below the knee. And what I encourage them to do is take a magged up view of an artery that they're trying to size on a specific magnification. And so for me, that's a 7-inch magnification on our Phillips system. And I feel I can size a vessel to a 0.5 millimeter for that. So I don't typically rely on IVUS for sizing. I do typically, if I need IVUS, it's not common, but it would be if I'm crossing a CTO and I'm really not sure if I've stayed in the vessel or not, I might use IVUS to try to prove if I've gotten outside the vessel somewhere along the CTO and trying to decide if I need to go retrograde to try to maintain an intraluminal crossing or not would be probably the most common reason I would use IVUS in my personal practice.
Thank you, John. Dr. Setcher, to the operator who maybe hasn't taken directional atherectomy into lesions this difficult, as we've talked about tonight, lesions like what John just showed, would you have any particular tips for those operators as to how to use the device in lesions like this?
Yeah, great question, Eric. So there is a learning curve for atherectomy, and among atherectomy devices, directional atherectomy has probably the most of a learning curve. But that's because it requires you to be more of a sculptor than other devices. You have the option and the ability to choose where you want to treat, how much you want to treat, but that comes with the responsibility to know what you're doing, because there's a risk if you don't know what you're doing. You can treat too much, you can potentially cause a perforation, but if done well, the risk of those complications is extremely low. And so I think if somebody is starting off and they are not somebody who does atherectomy on a regular basis or directional atherectomy, then I think starting off with lesions such as what you see in the reality is not the way to go. You want to start off with simpler lesions, eccentric lesions, focal lesions, maybe those in the popliteal and common femoral area, and less calcified lesions. But as you build up some expertise, I think after 10, 15, 20, I think you find that the learning curve is very steep and you get to a proficiency level relatively quickly. And once you're there, then I think treating patients with calcific disease is not hard. I would always advocate using embolic protection. As you saw from John's case, he had an embolic protection device in the perineal. It doesn't matter how small the vessel is. Make sure, especially if you have single vessel runoff, or if you have calcific disease or long total occlusions, use embolic protection. That gives you the insurance policy that you're going to be able to not cause something to get worse. And then when you're starting off, cut a couple of times, stop, pull back, and see what things look like. Specific to the types of patients seen in the reality trial, especially the long complex CTOs, it may be that sometimes you have to do a balloon angioplasty first before you can get the atherectomy device, especially an L system like John was advocating, because it is larger. But it's okay. If you use a 3 millimeter balloon, that's going to create enough space for you to get your atherectomy device down. You'll be actually surprised at the number of times this device will go through CTOs without any angioplasty. But if you add on to the CTO a lot of calcification, then you may need it, but that's okay. You get through the lesion, you put your embolic protection device in place, ensure that you do that, make sure you have enough space between the tip of where you expect the tip of the atherectomy device to be at the furthest part of the lesion and where the filter is, so you're not abutting up into the filter. And once you have that, then make your way slowly through it, take your time. And if you're concerned, after a couple of cuts, pull back, take a picture, and then treat as needed. Make sure you employ orthogonal views, because disease is eccentric. And if you have treated one area, you can't see the other side well. If you see haziness is often a marker of eccentric disease. Just go to a different angle and then treat in that angle. And again, take your time. Haste when you're going through these complex lesions can sometimes lead to bad outcomes. So again, it does take a little bit longer, but the outcomes are well worth it once you get used to it.
Excellent, Ravish. So a lot of good tips in there. Dr. Roka Singh, you have you've probably seen this data more in depth than any of us. You've seen our challenges, you've seen our complications. Are there any points that you would like to add to an operator with less experience in these cases?
I think, Eric, I want to reflect on what Rajesh suggested. We looked at a lot of data points, and I want to elevate some of his comments. The average length that the atherectomy device, we actually captured that in these long lesions, was almost 2 hours. That was the procedure duration. And as I reflect on that as a cardiologist, I know that some of my CT surgeons can do 4-vessel bypass in a shorter duration than opening up a 18 centimeter CTO. I think what Rajesh suggested, there is a learning curve here. And sometimes you do have to take it slower. You do have to use distal protection. You may have to do small vessel as you go through a CTO to get your distal protection device down there. And so all these issues of a graduated approach, these type of lesions are not for the beginners. And one of the criticism that's already been suggested to me is that all of you, I was not an enrolling site, are the creme de la creme, and that these results are not generalizable to the typical user. And I pushed back and I said, that's not correct. I said, what this data set suggests is that the advice that Rajesh provided and some of the cases that we've seen tonight suggest that this is something that is essential in any interventionalist toolbox. And I think it's incumbent on all of us not to send these patients for FEMPOP bypass, as was seen, but actually to get some assistance, go slow. And I think all of these are potentially approachable lesions for the well-intended and good techniques that interventionalists have.
I would agree with you, Dr. Roka Singh. I think this data set provides compelling evidence that there are multiple ways you can treat heavily calcified long lesions. It doesn't always have to merit a stent implantation. There are other ways, and they appear to be equally effective.
Yes.
So thank you for the time and taking us through all that data. I want to shift the focus just briefly to the concept of the issue of calcium. And I'm curious whether you think we can glean from the reality data set, we can glean any evidence that drug paclitaxel, at least paired with directional atherectomy, can increase the efficacy of the atherectomy alone. In other words, in this reality trial, do we find hints of evidence that paclitaxel works in severe calcium?
Well, I think there are some. I think one of the unique elements of the trial is the use of a histology core lab. As I mentioned, we in the U.S. we could not analyze tissue from our German subjects, but all U.S. subjects had their tissue analyzed. And I think is what's telling here is the efficiency and the extent to which we actually saw fibrocalcific and just significant amounts of calcium. So I think that the device does what it suggests, and it is excisional and it's directional. Now, how we will probably never in our careers see randomized controlled trials of this paradigm versus another. And I do think there are sort of preclinical data that suggests that maybe other devices may modify plaque. But I do think what it now focuses on in these complex lesions is that plaque modification and these pre-treatment of these long lesions is essential. And when I say plaque modification, it's not a good one-to-one predilatation with a balloon. It really has something more than just cracking, and it has to be something a little bit more substantial.
Thank you. Dr. Setcher, along those same lines, you presented data tonight from Definitive LE, where in that trial, there was no drug-eluting component. It was pure atherectomy and plain angioplasty with 1-year primary patency of 78%. So Dr. Roka Singh has presented the data from this trial reality, where primary patency is 77% at a year. Yet the lesion length was double that of definitive LE. The lesions were severely calcified, yet every single one of those would have been excluded from definitive LE. The patients were sicker, older, and it just makes me wonder if that's what paclitaxel brought to this equation, that none of us here today would have argued that these vastly different patient subsets could have put up equivalent patency at 1 year were it not for the paclitaxel. What do you think?
100%. There's no doubt in my mind that paclitaxel has an additive effect to atherectomy, and atherectomy has an additive effect to paclitaxel. The two of them together are a good combination. We've known that. It theoretically makes sense. And Krishna's presentation, the data that they've gathered proves that. So we can look at definitive LE and we can say, look, for 7.6 centimeter lesions, we had a 78% patency. Now we have 10 centimeters longer mean lesion length with more CTOs, more calcium, 54% diabetics. We have the same results. And we can look at that all we want. And I would just go back to John's cases. Those cases speak 1,000 words. It's almost inconceivable that if they had not received combination therapy, that those results would have been possible. So look, it is not that you're going to get those results in every single case. Of course, there's no such thing in medicine. However, when you take a large group of patients and you treat them in a systematic manner, in a particular way, when they're presented in a certain manner with certain lesions, what can you expect in your patient population if you employ this strategy? And I think what you're going to find is that done the right way, done with the right amount of time, with the right effort, you're going to have generally good outcomes, better than you would have had if you use either of these two technologies by themselves.
And Eric, if I might can I add a comment to that? Because I think there's probably some people watching this that don't have experience with a third generation atherectomy device. And so I agree with 100% with everything that was just said, especially your comments and Ravish's comments about these complex patients. But we could not have accomplished a reality trial with Silverhawk. So operators who only use the first generation devices say, the device just doesn't work in calcium. Y'all are all crazy. Hawk 1 is a different animal than what Silverhawk was for us when dealing with heavily calcified patients and lesions. So you have a higher spinning blade at 12,000 RPMs versus 8,000. You have breakers on the blade that help you cut the calcium. It's easier to clean. It's easier to cross. As Ravish mentioned earlier, a lot of times you can cross these CTOs without even having to pre-dilate them because of the tapered nose cone. So this device is much improved over the first generation device. So those operators who have only used the first, or even TurboHawk for that matter, the Hawk 1 is really much more capable and much more efficient in treating heavily calcified FemPop and below-knee disease. So I would just add that to the caveat that, yes, I do think paclitaxel added to the patency that we saw in this patient subset, but we also did a better job of debulking these type of lesions that we could have ever done in the DEF-LE trial, which historically only included Silverhawk and TurboHawk devices.
Thank you, John. Unfortunately, gentlemen, I think we've come to near the end of our time together. But John, I want to conclude with one final question to you. And when did you get the confidence that you could use these tools together and know that this would be an effective treatment with short and long-term gain?
I think just with years of experience using both of these modalities. And so, I've been using directional atherectomy for over 10 years. And honestly, we tackled lesions like this even before we had anti-restenotic therapy when patients didn't have another option. Because I think it was reasonable to offer a patient that option as opposed to amputation, which would have been their only option. But as you get more confidence, as Ravish suggested earlier, when you do simpler type A, type B lesions earlier when you're getting your feet wet with atherectomy. But what you'll find is that as you get more comfortable, there's really very little limitation in what you can do with the device as far as lesion length and calcification. So it just takes a little bit more time. And if you're saying, okay, well, I can clean the device, put it back in, debulk more, or I can see what my balloon does and I'm fine with putting a stent in, I think that's a personal decision. I spent the first 2 years of my practice fighting in-stent restenosis because of all the stents that have been implanted before I joined this practice right out of fellowship. And so I, very early in my career, decided that I wanted a stent-free strategy. And so now we have extremely low bailout stent rates in my practice because of that. And DA is the only modality that's offered to allow me to do that on a routine basis without implants. And so I think that as you use the device, you will find that you'll get more efficient and you'll have more confidence. And so I think the more you do it, the more you see your own results, the more confidence you will get in these two technologies together. And that's what I've seen in my practice. And of course, now I have, 3,000 or so DART cases under my belt. So I have the confidence to tackle that. But that only came with experience. I had to do my first DART case sometime, and that was, early in 2015. And I think everybody's got to do their first case. And as you get more confidence and see the results and see these patients coming back doing well, it just makes you want to continue to do that.
That's great, John. Thank you. Thank you for that insight and for sharing some of those cases in the reality trial with us all today. Gentlemen, I want to thank you for your insight, your dedication to this trial. I know it was an enormous amount of work for everybody involved, but thanks to you all for your insight regarding the data, for the tips and tricks of the utilization of these therapies in combination, and best of luck to all of you who have tuned in and listened today. Thank you all.
Thank you.
Thank you.